Yes, no.
I think in what I've found, that organic is an individual decision. It's not been proven to help, in the cancer survivorship, or cancer prevention. It mainly just means that they're not adding pesticides or things like that. It's not a bad thing to do, but it's your individual choice if you want to do that.
Hungry? Do you want me to grab
Oh,
something?
no, I'm fine.
Are you sure?
Yeah, I gotta go to the gym
I guess
after
I'll
this,
say
so I know
a small thing about it. I think it's important to distinguish between primary prevention and treatment of cancer. So there are certain things which we don't know in medicine, and other things we do which are very clear. What we know is through large retrospective studies, there are certain foods, for example, high-fat foods or nitrates, that increase your risk of developing cancer. But once you have a malignancy, it's not quite clear if it makes a big difference what you eat. And I was just speaking with somebody up front here about what I worry about as a clinician is most of my patients who have an active cancer who are getting treatment, they end up having a really poor appetite and end up losing a lot of weight. And so what I recommend is to eat healthy, but what I focus more on the calories to make sure that you're getting enough calories to sustain your body weight. And so if you're limiting your diet so much so by having such a restricted, well-intended diet, I discourage that a little bit. Not because I don't want you to eat healthy by organic food, not because I don't want you to eat good roughage, but because I really worry about patients losing a lot of weight through my treatment, which makes them not hungry. So I think that's, so in a preventative standpoint, then yes, I think that there's some very valid questions about organic versus GMOs versus other things, which we don't know may increase your risk of developing cancer. But once you get it, my most important thing is keep your weight stable because that'll help your treatment.
Dr. Switzer, you had mentioned that about 85% of appendix cancer patients are unable to have surgery at the time of diagnosis. Do you find that the use of chemo beforehand allows a lot of those patients to then have surgery?
So I intentionally kind of mushed a group of patients together, and I'm going to separate them. So I recognize this is an appendix cancer symposium. What I would say is that roughly 85% of people that have peritoneal carcinomatosis from any disease are unable to get a surgery. Now, the group of patients who have peritoneal carcinomatosis from an appendix cancer, that could get surgery is much higher. I think I would rely on the surgeons for the exact statistic of it. But I think if you have a tumor in the peritoneum from an appendix cancer, it's a higher chance you're able to get the surgery. But to get to your question, the more specific question of, is there a role for what we call neoadjuvant or before surgery chemotherapy is a complicated one. I think that it's not clear. I was talking to another patient's family out in Euphoria earlier, and for colon cancer, I can quote you a study with 4,000 patients and tell you very definitively that this is statistically significant and we should do this. For appendix cancer, there's only one randomized trial, and it had 36 patients in it. And so that tells you that most of the recommendations you're going to get are by expert opinion, not because there is a large amount of data to suggest, to prove whether it works or not works, whether it doesn't work. But what we do know is we do our colleagues, we have a fair amount of experience, so this is experience, that there are certain groups of people that will tend to do better with chemotherapy than not. And so we know we've found that patients with very low-grade or slow-growing tumors may not benefit that much from treatment beforehand. Although the tumors that tend to be very aggressive and doubling very quickly, those are the ones that the chemotherapies tend to be most active in. And as an institution, we've chosen to treat a lot of these people beforehand to hopefully make the surgery a little better. And so we've chosen that, and that's with some scientific rationale, but it's mostly expert opinion. I don't know if either one of you want to comment on that.
Well, I think that our goal in treating solid tumors is to increase the number of patients that can have that tumor removed. Nothing beats what we say a negative margin. You got to cut the tumor out, and so I think that whether it is intravenous or intraperitoneal or both therapies to increase the chances of being able to then remove the tumor. And then we can talk about, you have to do something to keep the tumor from coming back. But I think that is the way to go. The systemic therapies keep getting better. And so I think that by the way, the number of appendix cancer patients that I think that can have surgery from the time of diagnosis is very high. It's probably the other way around. I think that maybe 15 to 20% of them are not candidates. The true pseudomyxoma, the true PMP, I think all of them, it's the magnitude of the surgery is what's going to vary. But when we talk about colon cancer, or more aggressive tumors, then definitely the numbers keep diminishing.
Can you speak to the best follow-up regimen after surgery? Scans, for example, or other things you might do, and whether or not MRIs or CT scans are more appropriate.
Okay. Microphone? Okay. So, I was just having this conversation with somebody here a moment ago. I said, there's only 3 things we can do to follow up a patient after surgery. We look at the patient, we look at their tumor markers, and we look at imaging studies. So, you look at the patient, you get an idea. The tumor markers, not everybody has elevated tumor markers even before the surgery. And the imaging studies, everybody likes CAT scans. Why? It's quick. It's like that. When I was a resident, it would take 1 hour to get a CAT scan of the abdomen and pelvis. Now, I don't know, but I think it takes like no time. And most of us surgeons that are doing this type of work have gotten pretty good over the years at reading CAT scans, It's just 80, 70 cuts, depending on, how thin the slices you get. And we're pretty good at that. But I think that when you follow up patients, if you do CAT scans, there is radiation, so there is a risk. I don't know if anybody here from California, but in California, they're giving you the amount of radiation that you got when you receive your CAT scan. I seem like the lawyers are just preparing, for the secondary malignancies from increased radiation. Trying to avoid that, we have developed this peritoneal metastasis protocol MRI. And, Dr. Robert Barone from San Diego, for years has been talking about, we should do an MRI, we should do an MRI. And I confess, whenever I'm at the podium, and he comes up and says that, I would always say the same, said, Bob, please, not ready for prime time, not ready for prime time. But I think it is. I think MRI is definitely ready. We have been able to even characterize the mucinous deposits between, this is just mucinous ascites, or this is a hard tumor nodule based on the characteristics. So MRI is a much more dynamic test. And the problem is that, yes, you get about 1,200 pictures. Not everybody wants to, knows how to look at it. It's a lot more difficult on the patient. They have to hold their breath for 24, 48 seconds. Not everybody can do that. And it costs more, it takes longer, and it's harder to read. So it's a little bit difficult, but my recommendation would be MRIs. Now things are changing, MRI, a PET MRI is coming out pretty soon, and I think that's even going to change things a lot more.
I would agree. Just as Dr. Escobar described, as surgeons, we are very comfortable with reading CAT scans. They're very convenient. But we're here at UMass. We're also moving towards MRI. We did try to get a program going, but just recently in one of our tumor boards, we have a new radiologist who was there, and he was like excited beyond belief about what MRI could see in the abdomen, was telling us about all these new techniques, and then said, is there anybody here who would be interested in this? I was like, where have you been? And so I actually had invited him to speak today about MRI, but he was out of town, so next year I've already said you have to be around. We're going to find out a day when you're going to be around, so to talk about that. So I agree with what Dr. Escobar said. It's definitely coming. I think it's going to be the way pretty much everybody's going to go for the reasons that he said, but it does, for all the reasons that he just pointed out, it takes time to get a program together with somebody who's dedicated to it on the radiology side, who's willing to read the scans and think about the technique. It's not just like getting a CAT scan, it's much more complicated.
How do you know if you've got a radiologist?
I would add one more quick comment that will help kind of with that. So it's not just a simple CAT scan. A CAT scan is pretty much done the same way almost every time. There's a couple little nuances. The technique of the MRI and how they prepare to do the MRI can be drastically different. From the phases that they're looking at, from the bolus, the timing, the contrast. So there actually has to be a protocol specifically in place before they do the MRI. So depending on where you're at, you can't walk into a hospital in the middle of nowhere and say, I want an MRI for this, because they may not have the right protocol that will actually see what we're looking for. So I think it's a little more complicated than just saying we're going to go to MRIs. Our MRI is better. You have to have the MRI machine is roughly the same, but the protocol will say what they run the MRI can be drastically different to see what we're looking for. So they have to have it kind of prepared ahead of time. So the question is how do you know if your hospital does? You have to ask if they have a specific protocol for this.
And also, you can go on the web, if you just Google peritoneal metastasis protocol MRI, which we developed at my former institution, St. Agnes, is there. It's, available to anybody. The whole recipe on how to do it.
Can you talk about genetic link at all and what you know as far as offspring and whether there is predisposition?
I think that actually last year I gave a little talk about that. I think that what I would say is we have some very similar data. There's some very small series that show that there are certain mutations that are found in appendix tumors, and we're trying to figure out how to use them at this point. Whether they're high risk for metastasis, whether they're more aggressive. We're trying to figure out what to do with the information we have. I think this is a good time to be in research because we actually have more information than we know what to do with at this point. I would say that appendix cancers appear that they are rare tumors. I'd say that in colon tumors, to extrapolate for a second, in colon tumors, we know that roughly 20% of colon tumors have some sort of inherited link. It doesn't seem to be the same way in appendix tumors, but it may be just that we haven't seen enough of them to find that genetic link. So specifically for your children, there's not specific recommendations we do. There's not specific CAT scans we're looking for. We say traditional routine surveillance. As far as when you turn 50, you get a colonoscopy. If somebody has a first-degree relative with a known malignancy, then a primary care doctor would tend to have a lower threshold to do some sort of imaging if there is an issue. But there's not, at this point, there's no recommendations for surveillance for a first-degree relative.
I get asked that question a lot, and I say the answer to that question is I wish that we did know that there was a genetic link, because then we could just recommend taking everybody's appendix out, right? If we could identify people, that would be much easier than the appendectomy that Patty had, It would be much easier if we could do that. And I know that everybody who's in this field and sees a lot of people with appendix tumors, we're always looking for somebody who has a first-degree relative that had this. And I've never encountered it in my practice. I've never seen a report in the literature. Have you met anybody, a family, where more than one person has had it?
So about a decade ago, we put together 833 patients with appendix cancer from around the world. And I was the only one who had two brothers. One grew up in Virginia and one grew up in California. One had a low grade and the other one had a high grade. But that was so 1 out of 833.
I just wanted to add something about the MRI because I was a patient of Dr. Escobar's. I've had the MRI. I'm into my 4.5 years. I have my 5th year coming up soon in January, and so it is different from a CAT scan, but it's very doable. There's a little discomfort, but nothing out of the norm. And I just know when I'm going in there, I'm prepared to do what I need to do. And I'm very thankful that I've been able to have that because it's very, very clear and very distinct scans from the chest all the way down, so.
Sorry, a question about the innovations, the solution that melts in mucin. How does that affect IPEC? Is that a new solution for IPEC, or is it sort of like an add-on?
Yeah. So right now, so the question, I don't know if you could hear it, was about those, that study that I showed was dissolving the mucin from Dr. Morris, and right now it's still just in the preclinical stages, so they've put the combination of those two drugs on cells in a petri dish, and they've given it in the belly cavity in mice, and they've seen that it's impacting tumors. So the next step is going to be to see if they could do something similar in people. And they were, in their article, they talked about using it as an adjunct to the HIPEC, is what they were saying. So it's not quite, as Dr. Russell said, it's not quite prime time yet, but I'm sure they're working towards getting a phase 1 clinical trial to test the safety of it in people. So it seems interesting, for sure.
My question is on geography. It's more concentrated in certain parts of the country or parts of the world. It's more environmental world.
So the question was the geography of the distribution of appendix cancers. Is there any area in the country that sees a higher concentration of them? There was actually a report that just came out, not on CNN, it was in the 60 Minutes, about a community, I want to say in Missouri. I didn't actually see it, I just heard of the word, but St. Louis, Missouri. And they actually commented on a number of different types of cancers, including appendix cancer, in an area where there was some toxic dumping, and they've shut down that area, and they're studying that area. But that's the only one that I've heard about with and other rare tumors. Like, it was lumped in with other rare tumors, but they actually specifically mentioned appendix tumors in that area. So I think they're looking into that. But other than that, I don't know of any high concentration areas that have been picked up. Do you, Jesus?
No.
Most female patients are, from my research, they recommend bilateral cell tube strokes. Why not also the uterus at the same time, especially for postmenopausal women? And these cancers tend to occur after the 5th decade of life.
Well, I'll tell you, there's some of our colleagues who do recommend to do a hysterectomy. One of the things that we know, especially about these mucinous tumors, is they love scar, you know. So I think that if you do a hysterectomy, then you have that vaginal cough with a high risk of developing a recurrence there. I think that that's one thing. The other aspect, which I don't recommend the hysterectomy, the uterus is a very thick muscle, you know, and these low-grade mucinous tumors are very easy to clear the uterus without taking it out. Now, there's no easy operation for the patient. You know, taking it out for the surgeon is a small procedure compared to everything else. But there are urological, you know, urinary consequences. So I don't see why, you know, why you have to take it out if it's not involved to the point that you cannot clear it. Some of my colleagues say, oh, you need to get the gallbladder out, and even some of them want to remove the spleen. You know, oh, you don't need the spleen, you know, might as well take it out during the procedure. I don't know that. You know, I used to take the belly button on everybody. I cannot remember when was the last time I took the belly button. You know, they look awful for the first few months when you decide to leave it in. You know, they're all black and blue, and you say, oh, I'm going to have to take the patient back because it looks really beat up. But, you know, a year goes by and it looks like a belly button, you know, and I think some patients really appreciate that.
I would say one other thing, though, we know that the ovaries, as compared to the uterus, are an area where tumor cells like to land and grow. It's, you know, it's the seed and soil concept, you know, it's where the cancer cells are landing on an ovary, whether it's the hormones or the blood supply to the ovary that will incur. So it's a very common place for recurrence to occur, as opposed to, it's not, things might drop onto and be on the uterus, but they're not really, it's not like it's a place where they are attracted to necessarily, I think. And so, and for the technical reasons that Dr. Esquivel said, I agree with not taking out the uterus unless it's involved and it's the only way to get it out. But taking out the ovaries, especially in a postmenopausal woman, again, where that's an area where cancer cells seems to be attracted to, and it does not increase create a huge amount of scar tissue or increase the magnitude of the surgery, I think that makes sense.
Question for Dr. Switzer. As a layperson, I can relate to images and see whether the tumor's growing or not or whatever. But what I've heard today is that the abdomen shifts and everything else, so therefore you could have different sizes, different days. So what's a better indicator as to whether or not there's progression or regression? Is it tumor markers, SUV values?
This is a problem that we struggle with this disease specifically. What I would say is there's a study out of MD Anderson where they took patients and they did a diagnostic laparoscopy beforehand. They measured how much, just by visually looking at the tumor, they did a diagnostic laparoscopy, they saw how much tumor they had. Then they did CAT scans, then they treated them, and then they did CAT scans afterwards and another diagnostic laparoscopy. And what they showed, really interestingly enough, is that for most, unless there was really clear disease progression, the CAT scan actually couldn't predict very well whether it had grown or not. And that's because, as I kind of try to show you on the pictures, is that it doesn't grow, it tends not to grow in these big balls like they would in the liver. They kind of tend to grow on the top of, on the surface of the bowel, on the surface of the mesentery. I don't want to speak where the surgeons see it. I just know what I read about. And because the bowels are moving, the tumors may move in and out of planes a little bit. So I'd say that CAT scans are actually very difficult to interpret. And there's an actual study that shows that what we always experience is that they're difficult to interpret. Hopefully, with the use of MRI and the appropriate sequence MRIs, we'll be much better at determining whether there's actual progression or not. At this point, all we have is what Dr. Escobar said, is we have you as a patient, how you're feeling. We have the tumor markers, which upwards, depending on the patient, I mean, it could be upwards of 40% of patients will have no tumor markers. And then as far as the imaging, and those are the least invasive things. I wouldn't recommend, and I don't think my colleagues would either, doing a diagnostic laparoscopy every 3 months to see if it's working or not. Because that would be the only real accurate way to tell. But I'd say we're kind of limited by, we want to test how well it's working without harming you. And so we're kind of limited with that. I don't know if you want to comment on that either.
I have a question. Going back to talking about the ovary, is there any relationship between endometriosis with in the relationship to preparing appendix cancer?
I don't know of any correlation. So endometriosis is a perfect example of how things can really start in one organ and then spread. It's a benign condition that it can spread to the lungs. It's, ovary.
5 years before I came forward with the
Appendix.
I ended up having endometriosis in the other ovary, right next to the ovary,
The appendix? Yeah.
And just looking at the relationship.
I am not aware. I think that, sometimes you can have two conditions. One of the reasons why the mucinous appendiceal neoplasms tend to spread into the ovaries, the only organ inside the abdomen that is not covered by peritoneum is the ovary. And so it's for obvious reasons, you need to release a follicle that, that's what it's meant to function as. So it predisposes. So we like to take the ovaries, even if, depending on where the patient is in their childbearing situation and in their menopausal or not status. But
this question is for Dr. Lambert. I'm one of the, oh, sorry, in the back. I'm one of the nurses on the 6th floor, and I remember about a year ago or so, we were on the 7th floor, and I had a patient that had her second HIPEC done. So I was just wondering when do you know when to do a repeat HIPEC? It's my one and only patient that I've ever had. You guys are still fairly young. She had a really young son and everything. I just wanted to see if you could touch on when you know to do a second one.
So that's a complicated answer, and it's definitely determined on a very individual basis. As everybody has stated already today, there's so few people with appendix cancer that there's no set algorithms or big randomized studies that we can point to. So some of the things that we go by are how far out they are from their first HIPEC, how well their first HIPEC went, what their tumor is, what type of cancer they have. A lot of times people will, if they recur after their first HIPEC in a short period of time, we'll give them intravenous chemotherapy to see how they're responding and determine if it makes sense to do another cytoreduction in HIPEC. If somebody has a HIPEC and then recurs many years later and you've caught it at an early point in time where there's low volume, then it could make, and depending on what the tumor type is, could make sense to go back and do the HIPEC again at that point in time. But that decision about doing repeat HIPECs is really, really individual for each patient. And Dr. Escobar has actually published on the change when a person recurs, how much tumor they have to help you determine whether or not they would be a candidate for a HIPEC a second time or even a third time. There are reports in literature of people having up to 5 HIPECs, which is hard to imagine, but maybe, what do you think, Kenny?
yeah, I wrote that paper with Dr. Schillebaker a long time ago, and we had 98 patients with some of them having up to 5 HIPECs. And believe me, I was at that stage, I was still thinking like, wow, we're really good, we can keep going. But now I firmly believe that it's the biology of the tumor that has allowed us to be able to do that repeat surgery on those patients. It has nothing to do with our surgical skills. And so I think that's, the 3 things that I evaluate now is time, location, and amount. So if they recur shortly after the first HIPEC, it's a bad sign. If it's a location, if it's now just involved in the small intestine, it's also bad. And the amount, if the patient has more tumor now, when you consider a repeat cytoreduction than they had at the time of the first cytoreduction, those are the 3 things that would discourage you from doing another cytoreduction. Less than a year.
My daughter-in-law was one of the ones, she had a cytoreduction of my neck and had a lot taken out, and then a year later they took out a uterus because they found that the cancer had come back. They didn't do the HIPEC at that point, but and I'm not sure what else they took out. I think they had to let them take out HIPECs too.
I had a question about the study. You talked about this coming up. So the clinical trial?
Yes.
You had said that there's 3 things. 1, the person has to be well enough. 2, that they have that peritoneal cancer. And the 3rd was that there has to be measurable disease. Can you talk about what measurable disease looks like?
We have to be able to see something there. So for people who've had a HIPEC and we can't really see anything on any of the scans. We call it clinical equipoise. I don't know that we would want to subject people to chemotherapy who may not have any active tumor, or may not tumor that we can see at least. So I think that there's a lot longer on the list of things, but those are the major high points. You have to be strong enough to get the treatment. You have to be willing to do it. And you have to have some active cancer. And so those are the 3 things that we're really looking for. Those are the major things. Of course, you can't have bad kidneys, you can have bad heart, but I think that so for more specific information, I'm happy to talk to you afterwards.
Thank you.
And one more thing I would add right now, for people who would be candidates for HIPEC, this is trial's not for those people. We would recommend they go to HIPEC. This is for people who we're looking, so we can actually see the cancer on the CT scan, and we know they're not a good candidate for the HIPEC. So.
You're talking about what's new, et cetera. What's the future of immunotherapy in this?
Well, that's a great question. So I think, personally, I think that immunotherapy is going to be the new chemotherapy. I think that, so this last year in June of 2015, there was a big splash at our national organization called the American Society of Clinical Oncology, and immunotherapy has made a big splash in two specific areas. In melanoma, which people who used to be diagnosed with metastatic melanoma, you'd have an average overall survival of about 6 months. And I said to a room of people who don't have a lot of melanoma. But with the new immunotherapy, there's 50% of people living at 2 years. So it's made a huge difference in melanoma, and it's also made a pretty big difference in lung cancer. And so because it's made a big splash in those two areas, I would say is that now there are subsequent trials across many tumor types to see is it going to work everywhere. And the answer is we don't know. We wouldn't start extrapolating until we're sure, because there are side effects of the immunotherapy. But I think this is going to be the hot new area in oncology for the next 5 years. So I would say I will add one more thing about immunotherapy. It's not a new thing. We've been trying immunotherapy for 50 years or more in one version or another. And I would say is that sometimes I'm optimistic. That's why I do what I do. On the flip side is that I also know that we have to wait for the research because, for example, I'll use melanoma as another example. Is we found there's a specific mutation, a BRAF mutation in melanoma, only because we've doctors. Estevar mentioned he showed a study up there where they were using a molecule to treat KRAS, a specific mutation. Well, I think we need to run those trials to see if they help before we start treating everybody with them. So there's a mutation in melanoma called a BRAF mutation. And if you have this mutation in melanoma, there's a target for that specific mutation in melanoma. And it's literally kind of similar to the immunotherapy. It's revolutionized how people get treated for melanoma. They have people in colon cancer have that exact same mutation. We use that exact same drug, and it doesn't work at all. So I say that we're excited, we're optimistic, we're hopeful that this is going to work in many other tumors. But until there's proof, we have to have caution in our optimism.
Any other questions, folks?
I just had a follow-up question on doing HIPEC, why you don't do it if the tumors grow back. So I'm in a bit of a different situation because I had full hysterectomy, and appendectomy by accident, just the doctor spotted it as OBGYN, which turned into this diagnosis. So right now I have no known material left. I'm considering HIPEC. But if it grows back between chemotherapy and my decision, I think I'm not a candidate, I'm not sure, but I'm hearing that we don't do it if it grows back. Could you just clarify that a little bit more? Did I get that right?
So it's not that you're not a candidate if it grows back, especially if you haven't ever had it. That would be definitely the indication. If we know that you're at high risk because you were, something was found at a surgery and that's how you got the diagnosis and it had already spread outside of the appendix, then we know that and now that the surgeon got it all out, we know that even with chemotherapy, you're still at high risk of it coming back. So you need to be actively followed, CT scans or MRIs or whatever. And then at some point, if it comes back at that point, and you've never had a HIPEC, then you would, as long as, you're a candidate, technically a candidate for HIPEC at that point, you would definitely be, HIPEC would be recommended at that point, yeah. The not when it comes back is after a HIPEC, If you've already had a good cyto reduction and a HIPEC, and it comes back in 2 months, that's not the time to go back and do another one. That tumor is telling you that, you know, this guy's a problem, this tumor's a problem, and you're gonna need to do something different than HIPEC.
I just recently read about basket trials. It seems like, from what I understand, it's only maybe 5 to 10 people within a thing, and they're looking at different types of cancers and part of cancers. I think it won't be too many trials for a while. And it seems just, you know, different basket trials that are going on in appendix cancer.
Yeah, I feel like I know something they don't know. No, so yes, there is, so as I just showed you on my slide, it took me a year and a half to make one trial for 20 patients. That takes a long time to put this together. So what she's referring to is that there is a group of, we as an oncology, we're trying to redo how we do clinical trials. So rather than doing two years on one trial, what we're doing is we say we have this idea, and we would like to do many sub-trials within one trial. So for example, there's something called the MATCH trial, M-A-T-C-H. It's a big cooperative group trial, so everyone that belongs to a large cooperative research group can participate in it. So it can be open at 100 trials, 100 centers at the same time, or my trial is only open here. These trials can be open all across the U.S. And so, for example, the MATCH trial is what people who had to have a diagnosis of cancer and have active cancer and failed first-line chemotherapy. And what they do is they go back and they biopsy the tumor and they check your tumor for specific mutations. And they run about 680 mutations, known mutations. And if you have a known mutation that there is a target for, they'll kind of put you in a basket and say that you could be, so it doesn't matter what type, so whether you have appendix tumor or breast cancer or melanoma, if you have this BRAF mutation, then you'll be included in this BRAF targeted trial. And so the MATCH trial, which I just referred to, was attempting to enroll 1,000 patients in about 26 different sub-trials, and it opened for about 6 weeks, and in 6 weeks we enrolled 1,000 patients. And the MATCH trial is now closed in less than 2 months' time. So this is an exciting way to do research, because for now, as the old philosophy was that if I design a trial, and if Dr. Escobar has a patient he's interested in to refer to me, he sends me the patient, and they have to fly up and see me and only get their treatment here. With these basket trials, they can be opened up at any of the collaborative institutions and get the same treatment. So there's a lot of advantages for patients and to actually get research done quicker this way. And I think that over the next probably decade or so, we're going to see a lot more of these trials.
Any other questions, folks? Last call. Well, you're
Great. Well, thank you very much, everybody, for coming. We had a great time. I hope you enjoyed it. If there are any nurses who are looking to get the CEUs, there's a form